Hello, everybody. Thank you so much for joining us here tonight for yet another BCSS members only event. It is an absolute pleasure to be with you here tonight. My name is Phaedra Aldridge, and I'm honored to be the CEO of the BC Schizophrenia Society. But before we begin, I want to start by acknowledging that we are very grateful to be virtually gathered on Indigenous land. From our offices here in Vancouver, I'm grateful to be on the traditional, ancestral, and unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Tsleil-Waututh, and Squamish nations. Thank you for being a member of BCSS. Through your membership, you are helping us make us a stronger organization. A stronger membership gives us a louder voice on matters of importance to families who have been affected by schizophrenia and other severe and persistent mental illnesses. Now, there are many benefits to being a member. As a member, you can have access to events, the opportunity to vote at our annual general meeting, which is on Saturday, October 21st at 1 p.m. We hope that everybody will be there. It is going to be a hybrid event this year, so it's going to be virtual as well as in person. So if you're anywhere near Richmond, BC, please stop by and please say hello and join us for the AGM on October 21st. Being a member also gives you a chance to share your experiences on the website, on the podcast, and of course, take part in events like this tonight, as well as our social media channels. And because you're a member, you probably already know that BCSS is a long-standing provincial organization. In fact, we're turning 42 years this year, which is pretty impressive. But one thing has remained constant throughout all of these years, and that is that BCSS has provided education and support to family members right across this entire province. Whether you're in a more rural area or underserved area, we are there to support families and provide much needed education and support. Schizophrenia, as we all know, is a serious mental illness. In terms of prevalence, we've been using the figure that approximately 1 out of 100, so approximately 1% of the general population has this illness. But based on recent research, BCSS is now adopting 1.8% as the prevalence rate for service planning. One of the main goals of BCSS is to create awareness about severe and persistent mental illness, such as schizophrenia, and the many effects that it has. As we all know, there is still a huge amount of stigma and many myths that still surround it. And this not only affects the individual living with the illness, but of course the family members that love and care for that individual. We've been able to increase awareness about this illness in a multitude of ways. Thanks to our partnership with the provincial government and all of our partners, we now have more staff in rural and underserved areas. We have additional staff to support our younger generation through our kids, tweens, and teens in control programs, additional family support programs, as well as our Strengthening Families Together program. We also have our podcast, which is called Look Again, Mental Illness Reexamined. We're going into season 4, marketing materials and events just like this one. We have worked very hard to strengthen relationships within the community because we know we cannot do this alone. We work with ministries, we work with health authorities, and a variety of community partners. In order to have change, we have to work together. And that's where you come in. We need all of your support. As I said, we cannot do this alone. And we've come a long way, but we still have a long way to go when it comes to educating the general population about what schizophrenia is and the many effects that it has. We also want to create change within our province, and there again, we need your support. We need everybody's participation to make this possible. We must continue working together to build a province where those affected by schizophrenia and other severe and persistent mental illnesses receive effective treatment and support. We are working to build a system in this province where families are recognized as being an integral partner within the mental health system. And tonight, we get to hear from Dr. Neelakant, who will talk about Clozapine and how it can be successfully initiated within the community. Now, we recognize that prescription medications and treatments differ from person to person, and that Clozapine is just one of the medications used for the treatment of schizophrenia spectrum disorders. After Dr. Neelakant's presentation, we are going to have time for a Q&A session, and we'd really like to hear from you. And now's your chance to ask any questions that you may have about Clozapine. So please make sure that you click on the Q&A button at the bottom of your screen, and we're going to make every effort to try and get through every single question. You have my word. We are really going to try and get through every question. But if not, then we will try and reach you via email after, so we can answer every question that we received tonight. But before we get to that, I have to give a huge shout out to AA Pharma. AA Pharma is tonight's event sponsor. And now we're going to hear from Ryan. Ryan Unwin is the Director of Sales and Marketing with AA Pharma.
Good evening, everyone. My name is Ryan Unwin, and I am the Director of Sales and Marketing at AA Pharma. I am humbled and honored to be addressing each of you today and wish you each a very warm welcome from wherever you may be watching. On behalf of AA Pharma, thank you for joining us for this BCSS members-only event, Clozapine, the Importance of Early Treatment, with your guest speaker, Dr. Harish Neelakant. Events such as today's are tremendously important as there remains a clear underutilization of Clozapine for those diagnosed and living with treatment-resistant schizophrenia, a clausophobia, if you will, and yet a mountain of evidence to support its earlier clinical use. I personally would like to thank Dr. Neelakant for his vision, tenacity, and commitment to his community, his efforts to help build physician confidence with Clozapine, build the support to aid in the shifting of care from acute to community, and most importantly, improve quality of life for patients. AA Pharma is proud to support the BC Schizophrenia Society in its commitment and initiatives to provide all BC residents with community, innovative services, and outstanding advocacy support. For myself, this is truly the type of work that makes a difference. We value our work together with the BCSS, whose values and objectives align closely with our own in the sharing of ideas and insights, and again, with the goal to find ways of achieving meaningful change for the individuals and families we serve. Thank you again for the opportunity to support the BCSS tonight, and have a great night.
Thank you very much, Ryan, for your message. And I also want to give a huge shout out and a big thank you to Michelle Way, who we also work very closely with. Thank you to you both. And now I have the honor of introducing you to our speaker for tonight's event. Dr. Harish Neelakant is a clinical assistant professor in the Department of Psychiatry at UBC in Vancouver, as well as a psychiatrist working at the Vancouver General Hospital and in the Vancouver community. Dr. Neelakant, thank you so much for being here tonight. Over to you. The floor is now open.
Thank you, Phaedra and Ryan. Good evening, everyone. I'm very excited to be here with you to talk to you about something that I've been working on lately with the treatment optimization program in Vancouver with Vancouver Coastal Health, Dr. Randall White, a medical director, and BC Center for Clinical Excellence, Dr. Rolando Barrios. We've been working on making Clozapine more easily available for the community here. Today's, I'm going to start talking about Clozapine today by briefly talking about I'll give a brief introduction to what is Clozapine and where we use it. To start with, I think I just want to introduce the idea that schizophrenia, schizoaffective disorder are part of schizophrenia spectrum disorders, and they are a form of major psychosis. And in this presentation, I'm going to interchangeably use schizophrenia spectrum disorders for psychosis, which is the most important part of most important psychosis. And I'm here going to focus entirely on medication, and in particular on Clozapine. So for, I guess most of you know what is psychosis, what is schizophrenia, but for those of you who may not know, psychosis is distortion of reality because of hallucinations, delusions, and thinking disorder. A major form of psychosis is schizophrenia and schizoaffective disorder. The treatment often involves antipsychotic medication, or always involves antipsychotic medication, majority of the cases, big majority. And clozapine has a very important role. And the use of clozapine early on is very important, and that is what I'm going to talk about today. I'm going to start this by introducing you to how we treat psychosis. When someone develops psychosis, and we know this is schizophrenia, schizoaffective disorder, we often use first-generation antipsychotics, for example, haloperidol, clopixol, or second-generation antipsychotics, which is more likely you have come across, like risperidone, olanzapine, aripiprazole, quetiapine, all the newer ones. Fortunately, about 60 to 70% of people with psychosis respond to that, but there are about 30 to 40% who don't. And we call them treatment-resistant psychosis, as you see in the center block. And they are more likely to respond to clozapine. And about 30 to 60%, depending on which part of the world you see, respond to clozapine. And there are still a few people with psychosis who don't respond to clozapine. We call that clozapine-resistant psychosis. And we use other strategies. I'm not going to talk about the clozapine-resistant psychosis or the psychosis treatment in general. I'm going to focus today on clozapine. This is because this is one of the things that we don't do very well, or we have not been doing well so far. The case for clozapine, why clozapine is useful in treatment-resistant schizophrenia or psychosis. It comes from a gold standard study by Kane et al., which was published in 1988 in Archives of General Psychiatry. It is probably the only double-blinded comparison which showed that after you try first and the second antipsychotics, and a person is still not getting well, then the third antipsychotic should be clozapine. If you try anything else, it is not as effective. So since then, it's been available, but it's been difficult to roll out or kind of make it easier to access. Now, there is good evidence coming from different parts of the world. There's this study from Finland by Tihonen, which was published in Lancet in 2009. It was about 66,881 people with psychosis. What they found was clozapine was associated with lowest mortality risk of all major antipsychotics. It's the cause of lowest cause of death of any because of any reasons. Then there was a US study by Walker et al., 1997. Again, 67,000 people. Clozapine-treated patients had lower all-cause mortality than non-clozapine use. And then the last two are from England. Maudsley Hospital Schizophrenia Bulletin says clozapine was associated with lower all-cause mortality, both natural and unnatural, after adjustment for confounders. And finally, the NICE guidelines, which is the National Institute of Clinical Excellence that United Kingdom uses. They say clozapine shows the highest number of quality-adjusted life years out of all antipsychotics. And it dominated risperidone and olanzapine when used as third and fourth line. What it means is that it not only reduces the risk of suicide, but risk of death from all physical complications of psychosis and schizophrenia. For example, higher rate of mortality from the physical conditions like heart conditions or diabetes or high blood pressure or smoking-related cancers and other things. Now, the case against clozapine, why has it been so difficult to roll this out? One, not everyone responds to clozapine. Only about 30 to 60% respond, and the rest are clozapine resistant. Two, the adverse effects. the adverse effects sometimes worry people and they don't opt for clozapine. We'll look at the adverse effects first. The two adverse effects that are of major concern are neutropenia, which is a reduction in the white cell counts, and then myocarditis, which is inflammation of the heart. Now, as physicians, we are very careful about this. What we do is we enroll people with psychosis on blood monitoring, and we monitor their we monitor their physical health very closely when we are initiating clozapine. We have to start very slowly and gradually build up the dose to a therapeutic level, unlike other medications where you can start with the therapeutic dose on the first day. So for example, you have to start at 25 milligrams or 6.25 milligrams and gradually build it up to 300 milligrams, which is usually a therapeutic dose. And the next side effects that are manageable that we see on more frequent basis are excessive salivation, weight gain, which can lead to diabetes and other complications, constipation, and sometimes low blood pressure and dizziness. This is not an exhaustive list of adverse effects, but these are the common ones that we see. When I say common ones, the first two, neutropenia and myocarditis, are not common. They are about 1 to 3%. Now, having discussed the case for and against clozapine, would we call this gold standard? Whatever you may think, I would say if someone has tried 2 different antipsychotics and they have not responded adequately to treatment, then trying 1 more or 10 more different antipsychotics will not matter. The only thing that matters is clozapine, which may effectively treat the condition. Now, one may ask, what if this does not work for me? If clozapine does not work for you, then you may have clozapine resistance, and we would be willing to discontinue it and look at other options. You need to speak to your doctors. And again, one may ask, how about the adverse effects? Will they harm me? It's a very good question. The reason why we do all this frequent monitoring is to keep you safe. And almost every single time, we manage to keep people safe. What if I cannot tolerate adverse effects? Most of these adverse effects can be managed through treatment or lifestyle modification. Please speak to your doctor or ask for a specialist opinion if it still does not get better. Now, let us look at what it involves to go on clozapine. So if someone has tried 2 different antipsychotics and it has not helped them adequately, and they're considering clozapine, then we would do some blood work. We will do a physical examination, get some history. If we see if you are suitable for clozapine. If you are, then we register you with a clozapine company so that you can be safely monitored. And then we have to see you every 1 to 3 days or every week till we get to a therapeutic dose, which can be 300 milligrams. But in some clients, it can be as low as 100, 150 milligrams. It depends on the whether we reach the therapeutic levels, which is just over 1,200 nanomoles per milliliter. Usually, the highest dose of clozapine is 700 milligrams. Not many people go up to that dose, but smokers may need a higher dose. One may need one needs weekly blood work for the first 6 months, then every 2 weeks for a further 6 months. And after a year, they can just get their blood work once every 4 weeks. And fortunately now, we have what we call point-of-care devices which are like testing your blood sugar, like the glucometer. It just requires a little pinprick, and that's all it takes. And then once someone reaches a therapeutic dose and they have responded well, they don't have adverse effects, and they can be seen as frequently as needed. Sometimes we see them once a month, but I have a lot of people who are stable that we see once in 3 months. Now, where can we start clozapine? I think most people can start clozapine at their own house, the convenience of their own house. They can work, they can be with their family, do this at home, see their doctor or their mental health team and get this done. There's some people who have medical conditions and they need more closer observation. They may have to get this done in the hospital. Or if they're unreliable, they have been using drugs, then we suggest they use the hospital or a step down from hospital like Venture or Crest in Fraser Health. Why is early treatment important? I think you may all have heard this many times before. What we know is that the best prognosis for schizophrenia spectrum disorders is a good level of education or a history of work, a history of stable relationships. And the earlier we can do, the better it is. If we can help you get back to school, get back to work, get back into a relationship, help you prevent damage to your relationships and friendships, and also guide you on the pathway to understand your condition well, organize your disability, and have a satisfied and meaningful life. So for all these reasons, I would say it is important to get the treatment. If you respond to the second generation antipsychotic, even better. If you can't, you should try clozapine and not wait till later in life. Why starting clozapine has been delayed so far? I think this has largely been because of lack of awareness, lack of information. Also, there has been a bit of challenge with recent increase in recreational drug use. So sometimes the diagnosis is complicated. Your doctor, your team is not confident this is schizophrenia, so they may kind of defer clozapine or treatment until late. And what we know is that if appropriately treated, sometimes people even cut down their recreational drug use. Also, people are reluctant to get their blood work done. That's one of the things that puts off people from going on clozapine. And some people are very risk averse. They don't like the adverse effects. They don't want to take the risk. So it's another reason. And last but not the least, I think we have not had enough resources, and that is something that we have been working on as a part of treatment optimization program in psychosis in Vancouver and across BC now. What are the challenges in starting clozapine at home? Homelessness is a big problem because we need to see the person regularly. We need to know where they are and safe. So if they are homeless, then it becomes impossible to do that. They need to have a place where we can reliably meet them and monitor them. Recreational drug use can make things unreliable, and it is unsafe to do that because we need to monitor clients who are starting clozapine. It is often helpful to have a family member or friend to be there to support them if they're not feeling well. So it would help to have a family member or a friend. Again, like I said, the resources, the community mental health teams were not adequately equipped, but we have done a lot to manage all of those. I will not go into those details in this presentation. And lastly, medical complications. Some people who have medical complications, they may not be able to go on clozapine, or we may need to monitor more closely. And what that means is they need a hospital bed. And hospital beds are always full, and that may delay the treatment. What we have been doing as a part of treatment optimization program in Vancouver Coastal Health is we have created provision for adequate equipment. We have optimized human resources at the teams. We have created new educational material for patients and the families in the form of leaflets and videos. We are upping the clinical skills, maintaining continuing medical education, and also enhancing the requirements for residents, students, both in medical schools and nursing colleges. Last but not the least, who is the one who may benefit most from Clozapine? I'm not saying these are the only people, other people may still, but if you have one of these, then you should consider Clozapine as something important. If you have tried 2 different antipsychotics and they have failed to eliminate all the symptoms, then try to consider Clozapine earlier on rather than later, so that you can preserve your education, you can preserve your jobs, your relationships. And if you are 18 to 40 years old, that's the best age when you are medically fit, physically fit. It's a lot more easier to start Clozapine, a lot less complications. Third, are you struggling at study, work, managing home, relationships, unable to enjoy recreational activities? You should try and get well soon so that you can get back to your life. Fourth, if someone is having suicidal thoughts, Clozapine is protective against suicidal thoughts. It's one of the 2 medications that are extremely helpful in suicidal thoughts in someone with psychosis. The next one is tardive dyskinesia. It is one of the side effects, motor side effects of first generation antipsychotics in particular, but also can happen with second generation antipsychotics. If you're unfortunately one of those, then Clozapine is the solution for you. It can reverse tardive dyskinesia. It's supposed to be a treatment for tardive dyskinesia. And the last but not least, but again, you wouldn't know unless you tried Clozapine. If you have no major adverse effects with Clozapine, then it is even better. So I'm going to end my presentation at this point and open myself to questions.
Okay, thank you. Thanks very much, Dr. Neelakant. We have received a number of questions, and as we said earlier, we are going to try and address as many questions as possible, either during this presentation or this Q&A session until 7 o'clock, or we will respond via email to as many questions as we possibly can after. So question number 1. Now, Dr. Neelakant, you did touch on this earlier, but the question is, could you please explain what treatment-resistant schizophrenia is and why some people experience this?
So, like I said, I think simply put it, if someone does not respond to 2 antipsychotics, then we consider them to be treatment-resistant. But to expand it a little bit, I think as you would, most of you would know, antipsychotics that we use, first generation and second generation antipsychotics are mostly, they mostly work through dopamine antagonism. That is, they block the dopamine receptors, and that is how they work. But there are some people where blocking dopamine receptors is not enough. It does not work. In those people, 5-HT2A antagonism is the mechanism to work. It's like a serotonin receptor antagonism works. And that is how the Clozapine works. And that's why using Clozapine as a third antipsychotic rather than using repeatedly more antidopaminergic agents makes sense. And we got a separate terminology for that, and we call it treatment resistant.
Thank you for that explanation. And Dr. Neelakant, why do you think that some people do experience, and seems to be quite a large number, why do some people experience this treatment-resistant schizophrenia?
So, like I said, it's about 30 to 40% who experience this. These are the people who don't respond to dopamine blockade of dopamine receptors. can be a number of other reasons other than treatment resistance. It may be, like I said, if they are using recreational substances that make the psychosis worse, or they are not regular with their treatment, not adherent to treatment. So sometimes those can be addressed through compliance packs or depot injections. But if they have been tried and if they are still not feeling better, then clozapine is the option.
Thank you. Next question. So you did discuss some potential side effects earlier, but are there other side effects that we should be aware of, including movement disorders or any sexual side effects?
Thank you, Freda. Like I said, this is not an exhaustive list of adverse effects. These are the ones that we see regularly or we worry about and monitor closely. But there can be a long list, and that would be too long to go through here. Like you mentioned, though, it does not cause movement disorders, or it is least likely to cause movement disorders, like Parkinsonian symptoms. It is least likely to cause. What I said earlier was tardive dyskinesia, which is a kind of movement disorder, often with movements in the tongue and face that may happen with first generation and second generation antipsychotics. They can actually be reversed through using clozapine. And lastly, sexual side effects. Clozapine does not cause the hyperprolactinemia or some of the sexual dysfunction that can happen with first generation or even second generation antipsychotics.
Okay, thank you. Next question. Are there any dietary restrictions or things that one should be aware of if they are on this drug?
So it's a good question because there are no dietary requirements for someone to go on clozapine. But like I mentioned in the adverse effects, people can put on weight. Not everyone does. But again, eating healthy, maintaining a healthy lifestyle is important. Not just being on clozapine, but any antipsychotic or even just psychosis itself, we would say keeping to healthy diet, exercise will always help. And not going to healthy diet, I think most of us know, portion control, eating balanced diet, and exercise.
Which are good for all of us and good reminders for everybody. Okay, thank you. Next question. So what are the protocols for individuals who are prescribed clozapine? Now, I know you did talk about this earlier on the blood testing, so maybe just go into a little more detail around the frequency of consulting with a physician and taking those blood tests.
So, like I said, it can be very variable from person to person. But if you are a young person, and we can go both ways. We can go rapid increase in the clozapine dose, which is you can be seen every day or every third day, 1 to 3 days, till we get to a dose of 300 milligrams. So the clozapine dose is increased sometimes from 6.25 milligrams, sometimes 25 milligrams daily. Can be variable, like I said, but it can be increased every 2 to 3 days till we get to 300 milligrams, which takes about 3 to 4 weeks to get there. So for that duration, you do need to see your doctor or your team, your nurse, or alternatively, there's a easier titration, which we are now encouraging because it is safer in the community. It comes with less side effects, is increase at a slower pace of 25 milligrams every week. And it requires you to see your team only once a week, but you will have to meet your team for 12 weeks till you get to the full dose of clozapine. And after that, it can go down to once a month, once in 3 months as required.
Okay, thank you for that. Next question, is there a danger for someone going on and off clozapine So I think the question is, how does the drug's effectiveness change if a person starts and stops this particular drug?
So like with most antipsychotic medications, when someone stops the medication and becomes unwell again, they may or may not respond to the same medication. They may need a higher dose of medication. The same thing applies to clozapine. Two, more important than that, for particularly clozapine, is it takes a long time to titrate up to the dose, to the therapeutic dose. So it takes like you're setting yourself back. If you miss 2 doses of clozapine, you will have to go back to retitrate again, and it may take 4 weeks to 12 weeks to go back on clozapine again. It may feel very daunting. So we encourage people to stick to the medication. If you feel that they're not going to be able to do that, then maybe clozapine is not an option for them. But for most people, once they see it is effective, they see no reason to stop doing it on their own. I often say, talk to your doctor if you feel you need to come off it or you need to reduce the dose. Don't do it on your own.
Yeah, that's good advice for sure. Next question. Does Fraser Health still have their Clozapine Access Program? It was called the Psychosis Treatment Optimization Program, or PTOP. And yes, it does still exist, but Dr. Neelakant, I don't know if you would like to speak more to it, or if we could just put the Fraser Health link, as well as the link to BCSS educators for our team to be able to answer the question. But I'll leave it to you if you'd like to discuss PTOP at all right now.
I haven't worked with Fraser Health, so I don't know what exactly is going on. I know it's not been completely, it's changed in how it works, but I will leave it at that. I will ask someone from Fraser Health to respond to that question.
Okay, thanks. So in the chat, then we'll just put, just for everybody's information, we will put the link to Fraser Health website. And like I said, to BCSS regional educators, so you can reach out to someone on the team for additional information about that particular program. So thank you for that. Okay, next question. So thanks for all these questions. Like I said, if you have any questions, please use the Q&A chat box down at the bottom of your screen. They are still coming in rapidly, and we will try and get to as many as we possibly can. So next question here is, does lack of insight, anosognosia, qualify as treatment resistant even when some other symptoms do improve with other antipsychotics, such as a decrease in delusions? So it's a very good question. So does lack of insight and anosognosia qualify or mean treatment resistance?
So how we define treatment resistance medically, scientifically, is people who do not experience a 20%, at least 20% reduction in symptoms. So they can still have significant symptoms, right? Insight is not everything. Sometimes it is a defense mechanism that some people use, like, hey, I don't have this condition, but I will take the medication because it helps me. So it's okay. As long as they are able to function, I think that's the most important part. If they are able to get back into their work, their relationship, and they are happy, I think that's what matters most. Insight is not everything. If they get insight, even better, but not everyone does.
Thank you. And we didn't really touch on this, but as we all know, clozapine has been around for decades, since the early 1960s. And so there's a good question in the chat box. And the question is, are there any new medications coming out that can successfully compete with the effectiveness of clozapine?
So it's a very good question. We ask those questions ourselves quite regularly. There are a lot of new medications that have come. They all would go in the second generation antipsychotics, or sometimes we call them even third generation antipsychotics, the partial agonist, partial antagonist antipsychotics like aripiprazole, brexpiprazole, some of the other medications. But they have not been found to work in clozapine, treatment resistant schizophrenia or psychosis. Unfortunately, only clozapine is the one that's been found to be effective.
This is the million-dollar question, Dr. Neelakant. What do you think we need to get there? What do you think needs to happen so we have more options?
So fortunately, I would like to say, like I said, like 60 to 70% respond to the other antipsychotics that don't need close monitoring, all those things. But another 30 to 40% respond to clozapine too. So it's actually not a big proportion that is left at the end. And even for those people, I wouldn't lose my heart, simply because there are plenty of things that we can still do. We can reduce the symptom burden. And the most important thing is give the quality of life to the person and support to the family. So I don't know what will come out in terms of medication next. I hope we'll have a miracle cure. I will not be surprised if we have some miracle cures coming up soon with the rapidity of development in medicine at this time. It's just, it's a matter of time before we will find something.
And here's another good question. Another barrier, as we all know, is refusal to take oral medications. So Dr. Neelakant, the question is, do you see any injectable versions of clozapine being developed in the near future?
We have actually a lot of injectable medications, and they work really well. They work as well as the oral medications, sometimes even better than oral medications, because a person is less likely to forget them. The blood levels, the plasma levels are more steady. They let the person, give the person the freedom to live their life the way they want it. So some people actually come and ask for the depot injection right at the beginning. And it is something that happens in some other countries more frequently, where there is less stigma against depot injection.
Does clozapine resolve or completely remove, or possibly remove, fixed delusions?
It's a good question. Unless you try it, you will never know. That's what I would say, because like I've come across people have been told like this person will never respond to any antipsychotic, whatever you try, and we start them and they respond and say like, what is this? And then there are people like, I think, oh, they are going to definitely respond. Unfortunately, they won't. So I won't know. Unfortunately, there is no blood test or a scan that would tell me if this person's delusion will respond to an antipsychotic or not. And that's why the whole process is trial and error, unfortunately.
Yeah, you're a very popular man. There's lots of questions. Next question, does clozapine cause heart palpitations?
Heart palpitation can happen. Heart palpitation can happen when your heart races, tachycardia, which is benign, nothing to worry about. Talk to your doctor, they can help you with it. But there can be more sinister causes of palpitation, like myocarditis, heart failure. They too can happen. We know all antipsychotics can do that, some antipsychotics more than others, but we do monitor them very closely now. We can keep our patients, our clients safe. The science has advanced, like I said, quite significantly to a point where we can help most. And in a worst case scenario, we always kind of stop the medication, find something else that doesn't cause the palpitation.
Makes sense. Yeah, thank you. Now, there's a few questions here around heart concerns or heart issues with their loved ones. So in this particular case, there's been some adverse effects with heart issues. Like I said, I'm just reading through a number of questions here. And this particular individual has not been referred to a cardiologist, but has been told to keep his heart rate down. Do you have any suggestions for people who are experiencing some of those adverse side effects that you mentioned earlier in your presentation?
Thank you. It's It's a complex question, simply because palpitation itself can be dealt with in many different ways. A faster heart rate is seen initially when we are trying to start clozapine, but it usually goes down, gets back to normal without any treatment after a few weeks, in which case we don't need to do anything. Sometimes we need a medication like beta blocker to keep the palpitation down, but there are other times when we need a specialist opinion. We generally reserve the specialist opinion to when we need it. We can do a lot of investigation, but if you feel like you would benefit from getting a specialist opinion, talk to your doctor. Tell them that you would prefer to have a specialist opinion.
Okay, thank you. Now, there's also a number of questions in the Q&A about helping a loved one who is refusing treatment, which we all know is very real. Do you have any recommendations on how to encourage someone to seek medical treatment?
Well, that's $1 million question. It's the hardest part of my job, but that's one of the things that we have worked very hard in the treatment optimization program. So many different things. We have early psychosis intervention programs all across BC. That's something that they do, like intervene quite early in psychosis. And as a part of the treatment optimization program, we talked about motivational interviewing, how to engage people with psychosis who have no insight, addressing stigma quite early on, getting people with lived-in experience. That makes a big difference. They need more role models. And we have actually a lot of good role models, people who have had significant psychotic disorder and despite that have achieved very well in life. And I think the more people come out, I think that will help others to follow their footsteps. I think there's no quick fix to this. I think it's a slow process.
Okay, thank you. And the next question is, why do smokers often need a higher dose of clozapine?
So it's a technical one, so I'll not dig deeper into it, but it affects the metabolism of the clozapine. When someone smokes, the tar in the cigarettes, it enhances the metabolism, and therefore the clozapine is metabolized faster and the clozapine levels go down. But when they stop smoking, the metabolism slows down, so the clozapine is eliminated slowly, and therefore the levels get well to the therapeutic range quicker. So there are people who gave up smoking in favor of using vapes. And that works because vapes do not have tar. I'm not suggesting use vape. It carries its own health risks, but it is what it is. Often what I tell people that I work with is, don't change your smoking habits. If you're changing them, let me know so that I monitor your clozapine levels carefully. That tends to work for most people. If they are deciding to cut down, then I will adjust the clozapine dose accordingly.
You just want honesty around the smoking habits as much as possible.
Yes.
Yeah, makes sense. There's quite a few questions around weight gain, which I know you've touched on earlier. So this question, when clozapine is prescribed later rather than earlier, and there are a number of other factors such as drug involvement, as you mentioned earlier, how long do you think someone should be on this medication before the negative impacts of side effects and relapse issues outweigh the benefits of clozapine?
So it's again a very interesting finding. When people start clozapine quite early on in their life, they tend to tolerate it very well. I have not seen people develop major health problems later on because they were on clozapine. But if someone starts clozapine later in their life, after they have a number of medical complications, they're likely to experience a lot more complications. I don't know why. That's how it is. And again, what I said earlier, with neutropenia and myocarditis, the highest risk is in the first month to first 3 months. Although the risk is still there later on, it reduces significantly.
After that 3-month point.
Yes.
Yeah.
And people when they get older, when they are on multiple medications, have multiple medical conditions, they all interact with each other, and it becomes a little bit more messy to manage at that stage.
Yeah, and still staying on the same path as we were talking about the weight gain. The question is, do you treat the weight gain with other medications such as metformin?
We do now have studies to say that metformin helps with keeping the weight down. It is only one tool in the toolkit. And also, like I said, like the multiple factors that contribute to it. A person's genetic background, ethno-racial background, their dietary habits, all those things kind of contribute to whether someone is going to develop diabetes as a result of the weight gain, or will they gain weight as a result of clozapine.
Another question about the sexual side effects, and in terms of, and you said earlier that there's not a lot of sexual side effects, but we are getting some more questions around that. So maybe you could just dive a little deeper into some of those side effects that people may or may not experience in that area.
So just to clarify, hyperprolactinemia is a common side effect of first generation, second generation antipsychotics. So when the dopamine is blocked, the prolactin, which is gestational hormone, is secreted, and it affects, it can cause erectile dysfunction, menstrual abnormalities in people of reproductive age group, which is reversed by clozapine, or clozapine does not cause that. Now, one way the clozapine can cause some sexual side effects, although this is not common, I don't hear this in my regular practice. I've been doing this for quite a long time. But postural hypotension, when they have low blood pressure, it may affect, but it is very uncommon. It may be many other things that are happening in the person's life that may be contributing to the sexual problems that they have.
Thank you. And I'm just going to ask one, we're coming to the end, so we just have time. So if anybody has any burning question, please make sure to put it in the chat box and we'll try and get to it. But I just have a question, Dr. Neelakant. As you know, with here at BCSS, we're trying to include the family and make the family an integral part of the mental health system. So I'm curious if you have any advice in terms of how we can encourage even more clinicians across this province to include families in the discussions with their loved one. Do you have any advice or any recommendations or any comments on that?
I think I applaud you guys. You do a marvelous job. It's a delight to see you help families. And I really get excited when I see family with my client. Because often people lose the support of their families. It does not help them ever get back onto their trajectory of normal life. Unfortunately, if someone has no insight and they do not consent to involvement of family, it becomes very difficult. But we still can hear to the family. We don't have to, we cannot give the patient's details or information. We cannot share those things, but we can always hear the family. If you have concerns about your loved one, you can leave a message with your mental health team. the best thing would be to get the consent of your loved one, to kind of get them to allow you to communicate with their doctor and their mental health team.
And one situation that we hear a lot, which you would also see a lot, is where due to the delusions and the hallucinations, they don't want to include their family member in those discussions. And how can we address that if the individual with the illness is saying that they don't want to include mom, dad, or their loved one? How do we get around that, Dr. Neelakant?
It's a very complex question. Sometimes there are ways to do that when when a person lacks capacity. There's some other mechanisms, but not applicable to a big majority of our clients. When I'm talking about guardianship and other things, don't apply to everyone. Again, I generally like to encourage my clients to include the family, and I do that very gently, because going against their wishes never helps. Countering them actually makes their symptoms worse, their illness worse. So I generally take time to engage them. And I would encourage the families to do the same. Have patience, encourage them to engage, and also education is a very important thing, and reduction in stigma is a huge thing. I think a lot of people don't want to engage or don't want their families to know because they feel ashamed of what they have. They don't want their families to know how much they are struggling.
Yeah, stigma and those many myths that we were talking about before. So yeah, there's just so many questions that we could continue, and if only we had all the time in the world, or Dr. Neelakant, because we still have more questions. But I'm going to ask one more final one for the night, and then before we wrap up, are all psychiatrists in Canada able to prescribe Clozapine, or is that determined by specific training / qualifications?
Anyone can prescribe Clozapine. But unfortunately, we all kind of like to specialize in certain areas. And so therefore, so some clinics may not be able to offer that. For example, if someone's running a mood disorders clinic, they may not be able to they may not have the facilities to do the Clozapine monitoring, and therefore may not be able to do. Not because your physician cannot do it, because the system does not support them do it. But if someone feels it has been a problem to get someone on Clozapine, I would say go to the local Emerge or go to the local mental health team and ask them how to get on to Clozapine, or any antipsychotic for that matter.
Mm-hmm. Yeah, for sure. And now, before we wrap up, do you have any final words? Is there any topic that you were hoping we were going to address, or was going to be in the Q&A, which it still might be, and we just haven't gotten through them? Was there any final thoughts from you before we wrap up, Dr. Neelakant?
No, I think we have done well with the time we have. All I wanted to say is, like, hope is a very important thing. Being positive is extremely important. People who do well are very positive, hopeful, because treatment is evolving constantly, and who knows, we are getting better and better stuff. And even with the current treatments available, you can have a decent quality of life like any one of us.
And thank you for being here, Dr. Neelakant. It was a really informative and helpful conversation. So thank you for taking the time to answer our questions tonight and for your presentation. And we will be following up with you if there's specific questions. I hope you don't mind. And just so we can get back and try and get back to as many people as possible if people did have further questions about Clozapine.
Please feel free to connect with me for the questions. Thank you for the opportunity. Best wishes to you all.
Thank you. Oh, I'm not done yet. I'm still going to talk a little more, Dr. Neelakant, so you may as well stick around.
Okay.
But before we go, I just really want to give a huge shout out to the entire team all across the province, to all the regional managers, all of the educators, the provincial team. Thank you for everything that you do. It does not go unnoticed. Thank you for all the support that you provide our family members. I know you give your heart and soul into providing that support. And I'm so truly, truly grateful for everything you do out there right across the province, whether you're in a large city or not. So thank you to every single team member that's on this call right now. I've said thank you, and I'll say thank you a million times over again. I also want to give a specific, the hearts and all the messages there. Thank you. I'm giving a shout out to the team as well. And huge thank you to very specific people to make tonight's event possible. I just took the orders from Conan, Melissa, Andrew, and Marcia. Thank you for this event and for all the work that you put into it. Thank you to every single board member, both on the society and the foundation board, as well as the policy committee levels. Or policy committee members. You are all volunteers. You all give tirelessly to this cause and to support families. Thank you for all the hours that you put into it. I'm just so grateful that I get to work with the team I get to work with, the staff team across the province, like I said, as well as both boards and the policy committee members. I really am truly grateful for all your support and for all your help. And I'm also very grateful to you, all the BCSS members. Thank you for being a member of BCSS. Thank you for making our voice stronger. And the only way we are going to do that is to continue to build our membership and to continue to be a voice. And like we said earlier, we cannot do this alone. And I know I'm going off script and my team is going to, give me a whack, but a heartfelt thank you for being a member and for speaking out. For the only way we are going to make a difference is if we continue to talk about this illness, the prevalence rates, the effects that it has, the medications that's required, the fact that we need more treatments, earlier treatment, and the importance of having family involvement right at the beginning until that very end of the journey. So family members, I know it's not easy. Thank you for all you do to support your loved ones with this illness. And once again, to all of our members, you have my word that we are going to continue working hard to increase awareness about schizophrenia and other severe and persistent mental illnesses, and do everything we can to support families in every single community across our province. Thank you for being here tonight. Thank you for being a member. I hope to meet you at the AGM on October 21st at 1 p.m. We're all in this together and we truly can make a difference. So as Dr. Neelakant said, we need to have that hope, and the only way we are going to continue to have that hope and to truly make a difference is through working together. So thank you for everyone's support and hope to see you October 21st. Take care.